Hi, this is Dave Kirshner, and this is a brief YouTube video on scanning the gallbladder. It's not going to be an in-depth look of every little piece of pathology that we're going to find, but it's going to go through the basics of how to position the patient, how to scan them, and what are some of the findings that you're expected to find. Sometimes when we go about scanning patients, for whatever reason, we can be too general and not think of it in a proper clinical context. If that's the case, we might have a question like this. Are you worried that gallstones are the reason why your patient is presenting with? And then you fill in the blank. Again, there's no clinical correlation here. The three indications that we tend to think of are fever NYD, vomiting NYD, and abdominal pain NYD. Now, why don't we just use the lab work and the physical exam? Fever and tachycardia are often absent, and it's not uncommon for the white blood cell count and LFTs to be normal even. Now, studies have shown, looking at emergency physicians who have been trained, that considering it from a time point of view, as well as from a financial point of view, point-of-care ultrasound looking for gallstones and acute cholecystitis can reduce the length of time that a patient spends in the department until they get a formal diagnosis that can be acted upon, and it also reduces the cost to the system. When we think of this, or any test that we're due, we tend to think in terms of specificity and sensitivity. Here's my first joke on specificity. Ouch, that one's awkward. Now, unlike this cartoon where you're not going for great specificity, that's something that we'd like in any test. In the case of bedside ultrasound, looking for gallstone pathology, well, our specificity isn't that great, about 60 to 80%. On the other hand, though, we could use this as a test that looks for our sensitivity in terms of ruling out pathology. And when we consider the sensitivity of these tests, it's actually quite a bit higher, in the low to mid 90s. If we were just going to review the basic anatomy, we can first think of the liver and the gallbladder sitting right behind the liver. It's going to be connected via the cystic duct to the common bile duct. It runs along with two other friends, the hepatic artery, man I can't talk today, and the portal vein. In terms of dimensions that we should be aware of, and if there is something to lock in, these would be some good ones. We should see a maximum length of 10 centimeters, a diameter maximally of 5 centimeters, and the wall thickness should be less than 3 millimeters. In terms of the liver and gallbladder's location compared to the thoracic cage, it tends to ride right under the right lower ribs. The gallbladder will be posterior or deep to the liver, and I tend to think of it as taking on the shape of a partially filled balloon. Now, when we're going to look for the gallbladder, we have a couple probes that we can choose from, depending on the patient's habitus, our comfort, and a number of other factors. But the two that we generally look to are the curvilinear probe that's shown on the left, or the phased array probe that's shown on the right. For the most part, the curvilinear probe will be the better probe to use. It has a larger scanning window when we're looking at the relatively superficial gallbladder. However, there will be cases that you can't easily see the gallbladder, and you need to take an approach that isn't so much subxiphoid or subcostal, but you actually need to look between the ribs. In that case, it may be more beneficial to use the phased array probe. In terms of scanning the patient, we can think of three standard scanning positions. There's the supine approach. If we can't visualize it well, we can have the patient roll onto their left side into the left lateral decubitus, or even potentially having them sit upright. By having a patient move from the supine to the left lateral or to the upright position, it may allow the gallbladder to fall from behind the ribs or liver so that it's more easily viewed. Scanning in two positions, supine and left lateral decubitus, is customary, as that way we're able to document any mobility of intraluminal structures, such as stones and sludge, or the fact that they don't move, such as is the case with polyps and tumors. In most patients, the gallbladder is located close to the right midclavicular line, just below the costal margin. To begin scanning, place the probe in the longitudinal plane with the probe marker pointing towards the patient's head. Begin just below the xiphoid process and slide the probe to the right. Once you find the gallbladder, which should appear as an anechoic structure, You may need to tilt or rotate the probe around its long axis to align yourself with its long axis. Once you have done this and been able to sweep through the gallbladder on either side, turn the probe 90 degrees counterclockwise to view it in its short axis. Again, once you have identified it in its short axis, you should sweep through it from the fundus all the way to the neck. There may be times, as I mentioned, when you can't see the gallbladder with this view. At that point, it's possible to take either a lateral approach, as seen in the image on the left, or take a view through or between the ribs, as seen in the picture on the right. Sometimes even this won't help, and it helps to do what Faith Hill tells us to do, which is have the patient just breathe. Boom, mic drop, that was amazing. Okay, no, seriously. What you can sometimes do is have the patient take in a deep breath and have them hold their breath on inspiration. That may help pull, as they contract the diaphragm, it's going to pull the liver down and therefore the gallbladder down into a more visible window. That was friggin' awesome. So this should be the basic gallbladder anatomy that you see. If there aren't any stones present, the gallbladder should appear anechoic or black. Where the neck is, you should be able to see the main lobar fissure in about 70% of patients, and just cephalad to that, the portal vein. To some, it actually looks like an exclamation point. We can use the gallbladder's proximity to the lobar fissure and portal triad, as this is the only way to ensure that you're not misidentifying a loop of bowel or an oblique section through the IVC as the gallbladder. Ensure that the structure being identified as the gallbladder clearly communicates with the portal triad. Now, bowel will usually have peristalsis, and we'll come back to this, and the IVC can be identified because it will have flow within it if you put on color Doppler. It's very important to visualize the entire neck of the gallbladder. In order to ensure this, it requires gently rocking and tilting the probe until you can visualize the communication of the gallbladder with the main portal triad. The gallbladder neck should be traceable along the echogenic main lobar fissure, which again is present in about 70% of people. Now these are two videos of sweeping through the gallbladder in its long axis. The sweep that we are doing in the clip on the left upper portion of the screen is probably the better of the two because we can follow that neck as it goes all the way down to the portal triad. On the other hand, if we look at the one on the right lower part of the screen, while we have a beautiful view of the fundus, which is the lower or more caudad part of the gallbladder, we're not getting a good view all the way up to the portal triad. In both cases, again, patient's head is pointing toward the left side of the screen, and just to orient ourselves with that partially deflated gallbladder or balloon, this is how it appears. So whatever position we need to be in to get the long view of the gallbladder, we are now going to rotate 90 degrees counterclockwise to get the short axis views of the gallbladder. In both of these clips, the gallbladder is being assessed through its entire length in the short axis. You can slide or sweep, but be aware that you could potentially falsely elongate the gallbladder if you're sweeping. Again, the one in the left upper part of the screen is probably the better one because we can see it sweeping all the way down to the portal triad. To the screen left of it is the liver, and deep to it we can actually see the right kidney as well. Okay, just to go over those measurements again that we need for the gallbladder. Again, we want to sweep through the gallbladder in two planes, and to avoid measuring artifacts, we need to measure it certain ways. First of all, if we're measuring the wall thickness, it should be less than 3 millimeters, and we should be measuring it at its thinnest point. When we do measure it, we measure the anterior wall, and the reason for that is the posterior wall can sometimes look thicker than it is because of posterior acoustic enhancement. In addition to that, when we measure the anterior wall, we should be in the short axis so that we are most perpendicular to that anterior wall. In addition to that, we are going to measure the length and confirm that it's less than 10 centimeters. And again, as we go to the short axis, we confirm that the diameter is less than 5 centimeters. We also want to look for a sonographic Murphy sign. The way I tend to do this is I'll make sure that the probe is right over the fundus, or the fundus and the stones, and I'll press down. And I'll say, does it hurt more when I press here over the gallbladder? and then I'll slide my probe so that I know that I'm at least 5 to 10 centimeters away from it, and then I'll press down again. And I'll ask them, does it hurt more when I'm directly over the gallbladder or when I'm to the side? Again, we're confirming this binary question, is there a sonographic Murphy sign? Yes or no. So those are the basic measurements that we're going to take. Again, if you haven't written them down, now is a good time to write them down. But let's look at a couple other things that you might see that could confuse us. The first one is going to be a contracted gallbladder wall. This can be normal after eating a meal, whether it's fatty or not, or it can also be present if there's gallbladder disease that's led to some scarring. The clip that's playing to the left right now is a contracted gallbladder that has stones within it. We can see small hyperechoic areas within the gallbladder that have shadowing, and we'll have more examples of that in the upcoming clips. If we look to the second clip now, the one on the right, this is a contracted gallbladder that doesn't have any stones within it. Now, I'd like you to take a break for a moment and think of paper. Yes, paper for a moment. Now, whether paper's in the shape of a bunny or an airplane or the frightening Nazgul from the Lord of the Rings, it's still paper. It's just in a different shape. And you know what? The same thing can actually be said for the gallbladder. The gallbladder can take on a couple different shapes, and it can actually have a couple folds to it. It can have something called a Phrygian cap, which is just a fold of the fundus, but it can also have something called a Hartmann's pouch, which is just a gallbladder wall outpouching. These are normal variants, but they can actually be confusing. One patient that I scanned at one point looked as though they had two cystic structures. And I thought, well, is this going to be one gallbladder and something else? But as I swept through, you could see that they both connected. So in this case, it was just a folded gallbladder. Not all gallbladders are perfectly straight. This is a video clip of sweeping through a gallbladder that has a fold in it. The fold appears as a hyperechoic line through its anechoic structure. Of interest as well for the geeks out there, directly posterior to the gallbladder is the IVC, and right behind it is a small circular structure, which is the right renal artery, which you can actually follow back as it joins in to the aorta. Super cool, super geeky. Boom. Okay, so we've gone through a couple things. I just want to point out now what are going to be some of the differences between symptomatic biliary colic and advanced gallbladder disease, cholecystitis. In both cases, we should have gallstones present. There are a couple cases when you can have acalculous cholecystitis, and we're going to come back to that, but really we should be looking for gallstones to be present. Secondly, there should be a sonographic Murphy sign. They should be tender over the gallbladder when we press on it. Gallbladder wall thickening shouldn't be present in the case of biliary colic, but it may be there if you have cholecystitis, and that goes as well for pericholecystic fluid. We're going to go through the gallstones, gallbladder wall thickening, and pericholecystic fluid now, so you know what they can look like and some mimics of them, and then we'll put it all together when we look at some cases of acute cholecystitis. So again, gallstones, they should be hyperechoic with shadowing behind them. The image to the left of the screen that we have here, can you see a hyperechoic structure that has shadowing behind it within the gallbladder lumen? It is right here. That is the hyperechoic structure of the stone that's actually in the neck of the gallbladder, and there's shadowing behind it. If a stone is less than 4 millimeters, it may not shadow. Again, I say because it's important. If a solitary stone is less than 4 millimeters, it may not shadow, which would be a false negative read. Now we try to look for clean shadows. On the case on the right that I've just put up, this is actually multiple gallstones that are filling the posterior wall of the gallbladder. It can almost look like the posterior wall of the gallbladder if they're small enough and if they're numerous enough, but the reason that we know that they're stones is that they have the shadowing that we can see here as well. If we're concerned that this would be a stone or not, the next thing that we could do is we could have the patient move, such as rolling onto their left side, and ask ourselves, does this stone or this object move when the patient is moved? Now, shadowing is something that we look for in other structures, and we're just going to spend a moment to look at it a little bit more with gallstones. On this image here, we have both shadowing from a gallstone and shadowing from some gas within the duodenum. This is the gallstone, hyperechoic with dense or clean shadowing behind it. Compared to the duodenum, which you don't really see a definite demarcation, but you do see some dirty shadowing behind it. Dirty shadowing tends to be more associated with gas or air, whereas clean shadowing with gallstones. The only caveat I'll put to that is, again, if you were to have a very tiny gallstone or multiple ones that are kind of moving around, it might look a little dirtier. However, if you zoom in, it should still appear cleaner. Okay, so that's just a little bit on gallstones and their artifacts. Now, if we look at those gallstones, as well as a couple other findings that we can find, we're going to look at their shadowing and their mobility to determine what it is. Again, good things to write down. Number one, if it's mobile and there's shadowing, this is going to be a stone. The only time that it might be shadowing and non-mobile is if it's actually impacted in the gallbladder neck. If it's mobile and there's no shadowing, well, it could still be a small stone, less than 4 millimeters, or it could be a ball of sludge, which we'll sometimes see. If it's non-mobile and there's no shadowing, well, it's something else. It could be a polyp, it could be a malignancy or cholangiocarcinoma. Either way, it's out of our purview. Call for help in the forms of formal imaging. Here are 4 examples of gallstones within the gallbladder. I want you to take a moment, pause the video, and identify all of them before moving on. Okay, so I'm assuming you took a moment to pause and find them all. Here they are, pointing with the arrows in all of the situations. Again, you can see that their shadowings can look a little different based on the size that they are. I also want to point out in the image on the lower right side of the screen, the stone is actually sitting on a junctional fold of the gallbladder. So at some point this gallbladder is somewhat folded around itself. In addition to there being gallstones in the gallbladder, there can also be sludge. Sludge is known because it lacks shadowing and it tends to be quite mobile. The caveat to that would be if the gallbladder is completely filled with it, you may not be able to see it moving as much. The clinical significance of sludge is unclear, and in most people, it will be asymptomatic. Typically, sludge localizes to the dependent portions of the gallbladder and forms a bile sludge layer. That being said, it can still fill the entire gallbladder. You can get crystalline components to the sludge that can float in a non-dependent manner and look somewhat like a snow globe. You can also get very tiny stones that can actually produce shadows from within the sludge itself. This is a clip of the ever-elusive sludge ball, the evil and dangerous half-brother of dodgeball. I know, for the record, some of these jokes are only for my benefit. Thank you for playing along. We'll keep moving. Another interluminal finding, polyps. You might want to write down the words that are below these 2 images. They don't have shadows. They are not going to move. The fact that the ones that are less than 5 millimeters are more likely to be benign is important, and the ones that are greater than centimeter, they do have an increased risk of malignancy. Whether you measure it at 5 or whether you measure it at 1 centimeter, it doesn't matter. All of these patients need formal imaging, and we need to ensure that they have appropriate follow-up. Now, sometimes you'll have 1 stone, or sometimes you can get multiple stones, like in the case with this gallbladder. You can actually get so many stones, and you could have a gallbladder that's contracted that it's to the point that you get something called a wall echo shadow sign. Say what? That's right. You can get a wall echo shadow sign. And the reason that that happens is that you have a gallbladder that's completely stone-filled and contracted around those stones. So, the ultrasound can demonstrate these 3 findings. It can demonstrate a wall, which will always be hyperechoic. Just deep to that will be an echo. This is the echo formed by the hyperechoic stones, and immediately behind that is the shadow, wall echo shadow sign. This is a clip of a pregnant patient that has a wall echo shadow sign as well. The right of the screen is caudad and the left of the screen is cephalad. This is taken from an anterior approach, and as we sweep through the long axis of the gallbladder, we just have a very faint hyperechoic wall, and then we have the echoes that are coming from the gallstones, and then the dense, clean shadows behind it. This is another image showing much the same thing. Now, it's not just going to be that straightforward. Of course, there's going to be something that we confuse with this, and it's shown right here. Is it a wall echo shadow sign? Well, the fact that I said it's confusing probably tells you that it's not going to be it. It is something that's behind the liver, and it's sending off shadows from just behind its anterior wall. However, though, this, upon closer inspection, is the duodenum. Now, while we talked about the highly suggestive feature of the clean shadows versus the dirty shadows, there are also some anatomic indicators that don't rely on the pattern inside the lumen. Firstly, the gallbladder should be traced to the MLF and then the portal triad. Secondly, the duodenum can be followed back to the stomach. And thirdly, the outer wall of the gallbladder will be hyperechoic, while the outermost muscular layer of the duodenum will be hypoechoic, like in this case. So with that in mind, and with only this one view, do you think that this is the gallbladder in the center of the screen with stones and sludge in it, or do you think this is the duodenum? And again, just to orient yourself, this here is the liver, and these are our anatomic orientations. So, this is going to be the duodenum. And the reason we know that, even from this picture where we're not following it to the portal triad and we're not following it back to the stomach, is the fact that the outer wall is hypoechoic. The duodenum, hypoechoic, the gallbladder, outer wall, hyperechoic. I realize I'm getting a little off topic from the wall echo shadow sign, but again, this clip is just to show that the gallbladder wall that we see initially, hyperechoic, and the duodenal outer wall, hypoechoic. Okay, so enough about gallstones and their mimics for the time. Let's look at some of the other findings that would suggest acute cholecystitis, such as increased gallbladder wall thickness. I'll let you know right now that this is a very nonspecific finding, and the differential diagnosis is as such, which is very lengthy. Interestingly, non-biliary related edema of the gallbladder wall usually produces more marked thickening than does acute cholecystitis. Be wary about attributing gallbladder wall thickness to cholecystitis if no stones are visualized. In most cases, the clinical picture and the absence of a sonographic Murphy sign will also help you in not making this misdiagnosis. In the case of associated inflammatory disorders such as pyelonephritis or a perforated duodenal ulcer, a sonographic Murphy's may be present. In these cases, you are dependent on the absence of a distended gallbladder and lack of gallbladder stones to clue you in on the non-biliary origin of the process. I'm going to say this when I look at this. When I'm thinking of reasons for gallbladder wall thickness, I'm going to say it could be, well, almost anything, which means we've got to correlate it clinically if we're going to be looking at this appropriately. This is a still image from a 19-year-old patient who ended up having a malignancy with significant burden of disease. In his case, there is no evidence or signs of acute inflammation or acute cholecystitis. You can also see a little bit of free fluid just around the fundus of the gallbladder. If we're thinking about pericholecystic fluid, it tends to be anechoic fluid that we look for anterior to the gallbladder. This is a case of a gallbladder that's not quite in its long axis, but we have fluid anterior to it that actually seems to have some septations through it. Pericholecystic fluid alone isn't enough to say there's acute cholecystitis, but we want to put the whole picture together, like this. If we're thinking of cholecystitis, we should be looking for gallstones, such as the one found in the neck of this gallbladder. Now, you won't always see that the stone is impacted there, but the stone should be present. You should assess for a sonographic Murphy sign that we already talked about. You can look for pericholecystic fluid, as well as wall thickening greater than 3 millimeters, as shown here. The more of these findings you have in the right clinical scenario, the more likely it is that you have acute cholecystitis. This is a clip of a patient who has acute cholecystitis. The upper arrow is showing some thickening to the gallbladder wall, as well as a small amount of pericholecystic fluid as we sweep through. The lower arrow is pointing to a gallstone that's impacted in the gallbladder neck. If we look at another patient, this is in the long axis. First question I have for you as we sweep through this is, how many stones do you think there are in this gallbladder? Well, there are a number of them in the fundus. There's one that looks like it's the size of a small child's head, and then a couple smaller ones there. But if you miss it, there's actually one that's stuck in the neck of the gallbladder as well. So there are multiple gallstones, and the one we're most concerned about is that one down in the neck at the lower left part of the screen. In addition to this, we have a thickened gallbladder wall anteriorly, and we have hypoechoic pericholecystic fluid anterior to that. This patient also had a fever, abdominal pain NYD, elevated LFTs, and they looked horrible. This is what acute cholecystitis can look like. Now, as we're getting near the end, just to touch on a couple brief points, acalculous cholecystitis. This is a term that you will hear talked of, but it's near impossible. Just like it's almost near impossible to not point and laugh when you see horrible lip implants. Let's just say this. About 5% of cholecystitis will be acalculous in nature. But just like pointing and laughing at horrible lip implants wasn't first studied in the ER, neither was acalculous cholecystitis. It was originally studied in an ICU setting where the causes ranged from extensive burns, write that down, to recent major surgery, write that down, significant total parenteral nutrition, write that down, or major trauma, write that down. So technically, you can still find it in the ER populations, but more so really considers it secondary to another problem going on. Now, that's enough of that image. If you have cholecystitis that's gone on so far, it can become advanced and it can present in a couple ways. These tend to be the patients that are later to presentation, whether that's because they've been flown down from a northern community or they've been sitting in a personal care home for some period of time. In addition to pericholecystic fluid, you can get wall disruption that can occur in these advanced cases, which can even lead to abscesses. And if we learned anything from the Alamo, any wall perforation leads to a higher chance of death. Boom, that was amazing. Along the spectrum as we continue, you can even find emphysematous cholecystitis. Approximately 1% of patients with cholecystitis will have emphysematous cholecystitis. The reason it's a concern is that it can be rapidly fatal in about 15% of patients. Risk factors, well, about half of them are diabetic and half of them are male. I guess I could also then say that half of them are diabetic and half of them are female. A portion of them will also have no gallstones to keep in mind. These patients need urgent surgical management, broad-spectrum antibiotics as well. Gas can be seen within the wall and lumen of the gallbladder and again is characterized by dirty shadowing as is pointed out by the white arrow in this image. Movement of the gas bubbles can be precipitated by pushing down or moving the patient. You can also get a gangrenous cholecystitis. This is again a form of advanced cholecystitis with sloughing of the membranes, a wall that has irregular and fluid collections, and air within the wall itself. You may even lose a sonographic Murphy sign in this case in about 2/3 of the patients, and that can be due to necrosis of the nerve supply to the gallbladder. Beware of this in the elderly diabetic patient. We're almost at the end, but I just want to point out another finding, which is the porcelain gallbladder. 95% of patients with porcelain gallbladders can have gallstones, and this is a condition that's thought to be related to chronic inflammation of the gallbladder. It's thought to be associated originally with about a 15% chance of malignancy, but now it's estimated to be about a 5% chance of malignancy. In this case, you can see a calcified anterior wall to the gallbladder, but you should see some shadowing. And you may, though, whoops, I went too quickly, you may still see the posterior wall, as in this case. With these patients, the treatment still tends to be to take out the gallbladder prophylactically. This is now going to be the summary side for this part, just so you know. The checklist that we're looking for once we've been able to position the patient and identify the gallbladder is we need to look at that gallbladder in terms of size, wall thickness, gallstones, sonographic Murphys, and pericholecystic fluid. Some of the main pitfalls that people will come up against are misidentifying a loop of small bowel or IVC as the gallbladder, missing an impacted stone in the neck of the gallbladder, failure to identify small non-shadowing stones, and forgetting to scan the patient in 2 different positions to determine if something's mobile or not. That is going to be the end for this short YouTube video. I hope you enjoyed it, and thanks for watching.